Okay, hello everybody, and welcome to the webinar entitled NAG, an Early Indicator of Renal Disease. My name is Kelly Scribner-Doring, and I'm representing ALPCO Diagnostics, the host for today's presentation. I'd like to thank you all for joining us to hear Dr. Robert Price's presentation on an exciting topic that we are confident will generate a great deal of interest for the audience. Before we get started, I just want to mention a few housekeeping details. The webinar is scheduled for 50 minutes, including time for questions and answers. If you have a question, please type it into the question box at any time during the presentation. The questions will be answered at the end of the talk in the order in which they were received. And if any questions remain unanswered due to time constraints, we'll provide these answers in a follow-up email for you. The recorded webinar will be made available in the next few days to all of those who registered. So before Dr. Price gets started, I'd like to provide just a little background about ALPCO Diagnostics. There we go. And so ALPCO was founded in the early 90s as an importer and distributor of immunoassay-based products. And since that time, ALPCO has engaged with over 60 collaborating partners, and in 2007 launched its own product line specific to diabetes and obesity. ALPCO's product offerings have expanded beyond immunoassays to include reagents for mass spec, HPLC, and flow cytometry, and most recently ALPCO's own Stellix brand of chemiluminescent immunoassays. While our vision has expanded to serve a broader segment of life science research and healthcare professionals, our mission to deliver scientific solutions for life remains the same. ALPCO's product portfolio is quite extensive, with over 1,000 immunoassays currently available. In recent years, we've built out our toxicology line to include a number of kidney injury markers, including NAG, which is the analyte of interest today. And with that, I'd like to introduce our guest speaker, Dr. Robert Price. Professor Price is the Managing Director of PPR Diagnostics Limited, the manufacturer of the Rapid Chrome NAG test kits. He currently holds emeritus faculty positions at King's College Medical School in London and was previously Head of Research and Head of Molecular Life Sciences Group in the Division of Life Sciences. Professor Price was a Fulbright Fellow at Harvard Medical School, and he obtained his PhD and doctorate in science from the University of Wales. Professor Price's research is focused on the underlying mechanisms involved in renal disease, with particular emphasis on diabetic complications and genetic disorders of the kidney, which has led to the publication of over 250 peer-reviewed papers, books, and articles. So please join me in welcoming Dr. Price as he discusses NAG as an early marker of kidney disease.
Hello, can everybody hear me, hopefully? Well, first, what I want to discuss today is I'll divide the talk into a number of sections. First of all, an overview NAG and how it developed and why we think it's of interest. Sorry, we're just in the screen here. Look at its physiological relevance, talk about a little bit about its clinical utility, discuss the basic assay procedure and the differences between the types of kits we have available, which is the enzymic and the spectrum using Calibrant and Spectrophotometric methods. Finally, I'll talk about some of the key selling points, features, and benefits. I got control. Yeah, I got. Sorry, we're just trying to make sure we got control. Yeah, sorry, there's a transatlantic drift there. Let's say a little bit about the enzyme. Well, N-acetyl-B-D-glucosaminidase, which is a bit of a mouthful, which is why it was shortened to NAG. It's a lysosomal enzyme found in high activity in the proximal tubule of the kidney. It's found in low amounts in normal urine. This is really due to standard gradual cell turnover. It's also found in serum, but the isoenzymic form in serum is different from that in urine and different from that in the kidney. There's a placental form of NAG which appears during serum in the pregnancy, and this disappears at parturition. The isoenzymes of NAG, hex A and B, are used in the diagnosis of taste acidity. This is really a rather different field. It's a very interesting field based on genetics. Sorry. Yeah, there's a time lag. Okay, we've got the right slide now. The molecular weight of NAG is 150,000. The advantage of this, or the interest in this, it precludes its filtration through the glomerulus. The cutoff of the glomerulus is about 67,000, 68,000, which is the molecular weight of albumin. So there is normally a little bit of leakage of albumin, but that's rapidly absorbed by the renal tubule. Elevated levels of NAG in urine arise, therefore, either from tubular or glomerular damage, so they won't come through the normal glomerular filter. Activity recovered in urine can be increased really quite substantially, up to 20-fold in acute damage, for example, rejection episodes or acute kidney injury. Another advantage, it's stable in urine at -20 degrees for 6 months, which means you can accumulate samples during a study and then do the assays at convenience. How did we come across this? Well, we were carrying out nephrotoxic studies in animals, and the enzyme we were particularly interested in was a beta-glucosidase, another glycosidase enzyme. And this was identified as a good indicator of renal tubular damage in rats. However, when we tried to use this enzyme with patients, we found it wasn't that useful for various reasons. But we came across another one, which was the NAG. And during a blind study, which we carried out with St. Bartholomew's Hospital, we used renal and surgical patients. These key early studies demonstrate the diagnostic potential of NAG as a biomarker. We've then spent some time working on the biochemistry until we got a telephone call from a renal transplant surgeon and asked if we knew an early indicator of rejection. It was at that point in time, rejection really was a major problem. So this was the data we obtained, the work we did with the surgeon. We looked at 2 levels of surgical trauma. One was a major trauma, which, let's see if I can work the mouse. Where's the arrow? Oh, we got the arrow. So if we look at this line here, so there's your normal level of NAG, which is a dotted line. So major surgical trauma, carry out the operation just before here, and up shoots the NAG activity. Where you and the surgeon basically just moved the kidney a little bit, and you basically got a little bit of a kick in the enzyme, and then you stayed just about normal. So there was a relationship between the extent of trauma and the excretion of the enzyme. The difference between these 2 panels is that this is expressed per milligram of creatinine, and this is per minute. It's essential to express the results either in a clearly timed sample or in terms of creatinine, preferably in terms of creatinine, as this is a direct measure of muscle mass. So it gives you an idea of the concentration of a sample. So if you look at the table, the first group here are the low trauma. So you can see the difference between preoperative and postoperative values in the enzyme. You see the rise. But then if you look at the more severe trauma, you see really quite major increases in activity. So there was a relationship between the severity of damage, physical damage or surgical damage, and the excretion of the enzyme. Now, we then looked at renal disease with a renal physician, and initially we started off he characterized the patients, the classical sort of glomerulonephritis or urinary tract infection or pyelonephritis. And what we found was, if that's, again, the dotted line is the normal range, and then if you look, they're all over the place. So there wasn't really a great relationship. And then he thought about it, and he regrouped them in terms of, he forgot about the clinical definition of disease, and he basically said, was it an active disease? Was it high GFR? By high GFR, was the renal function good or high? And then group 2 was active disease but low GFR. Group 3 was inactive disease, low GFR, long-standing renal disease. So as we go down, the activity disease drops, and there's the functional activity goes with it. So then when we replotted it, you get a relationship. So there's a relationship between the excretion of the enzyme and the activity of disease, and this relates to the function of the kidney. So you'll get greater excretion, whereas high activity and high normal function. This is a more clinical presentation of the results. So basically this is a patient with nephrotic syndrome due to proliferative glomerulonephritis. So here we have urinary NAG plotted, and at this point steroids are administered, and this is urinary protein. So you see the NAG, it stays high as the effect of the steroids improve, so it drops down to normal. And at the same time, serum albumin goes up, serum creatinine falls, and urine volume is more or less standard. This is an example of a renal transplant patient. So the upper triangle is the NAG activity, and this is serum creatinine. So the allograft was round about here, and you see the serum, it did quite well, the serum creatinine fell, and day 6 it looked as if it was doing quite well, but the enzyme was going up, in other words indicating there was a serious problem. So they waited, so when the serum level was there, they treated for rejection at this point. But what this indicated was there was a problem, and it was in fact an early warning of the rejection that did occur. At this point we've done about 500 transplants in renal patients. Many more have been done subsequently. It confirmed that urinary NAG was a sensitive indicator of rejection and renal disease. So it really was proving very useful. Although I was interested at that stage in the diagnostic value of NAG isoenzymes, there was also interest in the possibility of a dipstick test. Initially, the assays were carried out using a fluorometric procedure we developed. But in order to make it more generally applicable to various types of laboratories, the colorimetric method was required. So the surgeon actually christened it. He said, why don't you go and get something red for danger? And fortunately, with the help of some very good chemists, we were able to synthesize the first of two series of chromosomes. So we had 2 series of chromogenic substrates. The first one, the kit is based on, is MNP, which chemically is 2-methoxy 4,2-nitrovinyl phenol. I've lost the arrow again. Here we go. These are 2 patients. The first one is a 28-year-old female patient recovering from renal failure. So she's maintained on peritoneal dialysis. So at this stage she was on dialysis, then she began to produce urine. So if you look at the NAG, which is the dotted line here, you see it's high. As the kidney recovers, down comes the enzyme. This is an older patient who developed renal failure following surgery, and again, the dialysis here, the urine levels were quite high. They came down, but in this patient, it never quite got back to normal, indicating that he did need treatment. This was a bit serendipitous. We were looking at various patients. This patient was on dialysis. So you see 2 peaks of enzyme increase in the urine, quite high. These were dialysis related, and then everything stabilized, and all of a sudden up went the enzyme again. And when we went back to the case notes, what had happened, because he had toothache, he was put onto gentamicin, and this is a result of the nephrotoxic effect of gentamicin. So this led us into, apart from the surgical and renal disease, into the idea of looking at nephrotoxicity and chemical engineering, in particular drugs. So why is the kidney so susceptible to nephrotoxicity? First of all, it's got high renal blood flow. So I think about 25% of the heart supply hits the kidney within a minute. So it's very, very rapid. So any toxin or agent in the serum or blood will get to the kidney very quickly. The chemicals are concentrated in tubular fluid by reabsorption, so even if they get into tubular fluid, they're then reabsorbed. Tubular transporters cross the cells, which means that there's maximum chance for the compound to accumulate in tubular cells. In the top of this, the kidney is a very active metabolic organ, probably next to the liver and the brain. And chemicals can be biotransformed into toxic forms. And also a number of chemicals, some antibiotics, can induce an immune response. So there are various requirements for biomarkers. So how does NAG fit with these? Well, it's stable in urine. It's also stable when refrigerated or frozen in aliquot, so it can be used for long-term studies. The variation in age, gender, and ethnicity have now been determined, and the reference ranges and values are available. Possible effects by inhibitors in the urine are eliminated in the assay procedure. It's actually been studied in a wide range of diseases at different stages. For example, it's useful in acute disease, and as we saw earlier, it can be used to monitor the progression of disease. It responds equally well to different types of nephrotoxic insults, and this goes from drugs used clinically to environmental toxins. So what are the required characteristics for a urinary test? We must compensate for urinary flow by expressing the data in terms of creatinine concentration, or if it's possible, and very often it's not, to determine time samples. NAG test has high sensitivity, and procedures minimize the effect of inhibitors and interfering compounds. It's simple and rapid, which means it can be readily automated. It can be used in a range of laboratories, from very basic through to highly technical. Care in sample handling, you have to be very careful, particularly for multiple assays, because buffers can be used for different tests, and you do need to make sure you have the right buffers. The other point that many people miss with kidney is it's not possible to find a standalone biomarker for kidney disease, such as troponin for heart disease. Troponin originates from a very specific muscle fiber in the heart, whereas the kidney is a very complex organ. In fact, it's 2 organs really fused together. So it's more than likely you'd have to do 1 or 2 tests, or maybe more than that, more panel of tests. So NAG has been used to monitor progression as well as acute changes, such as those seen in AKI. And it's also got potential for point of care. So established biomarkers, NAG, microalbuminuria, it should be alpha-1 microglobulin, alanine peptide microcytes. So NAG lysosome enzyme, microalbuminuria, small quantities of albumin, not small albumin. Alpha microglobulin is a low molecular weight protein. Alanine aminopeptidase is located on the breast border or the membranes of the tubules. The microscopy is the classical way of looking at kidney. There's some recently developed biomarkers, and these not usually based on immunoassays, and they've come from sort of metabolic studies or using some of the modern technology. So we have KIM1, NGAL are the most well known. And then we have another interleukin 18, and then the number of matrix proteins. These are probably quite useful when it's suspecting fibrosis. So collagen derivatives or laminin, and then there's liver fatty acid binding protein. There are others, but these are the most significant recent ones. This illustrates the point that depending on what you're doing, you may be worth doing more than one marker. So if you look at, this is rats injected with gentamicin. So if you look at the top panel, you see that on the left-hand side, it's number of fold increase over normal. And you see the NAG is elevated quite early. You get significant values. Where's the arrow gone? Here and here. So 4 to 8 hours. Whereas KIM1, you get a more gradual increase, and you get the significance at 24 hours. So they're measuring different effects. So you can look at the progression of disease using different biomarkers. These are examples, it's a very large list, but of the sort of nephrotoxin potential to cause AKI or acute kidney injury, previously known as acute renal failure. So on the left-hand column we've got the type of toxin. On the right we've got various examples. So the therapeutic drugs widely used, they're aminoglycoside antibiotics, cyclosporin, cisplatin, diuretics, and lithium. Now the fact they're nephrotoxic means you're not precluded from using them, but you have to carefully monitor their use. For example, cyclosporin is renal effect is monitored, and you can switch between steroids and monoclonal antibodies. Cisplatin was withdrawn originally and then brought back because they could actually found a way of controlling the effect on the kidney. Lithium is anti-manic depressive drug, and this is widely used, and this seems to be a cumulative effect. So again, you need to minimize the dose and monitor. Diagnostic agents, contrast media. There are a number of immunoallergic agents, for example, penicillin and sulfonamides. You've got the immunological side effects of mercury, gold, and D-penicillamine. If we move to the industrial sector, we have solvents, chloroform, styrene, butadiene, which is used in large amounts of the plastic industry, carbon tetrachloride, of course, in the cleaning industry. Then the well-known effects of metals, of cadmium, mercury, lead. Then the agrochemicals, and certainly the European Union is successfully banning and introducing different agrochemicals to avoid the toxicity effects. Fungi, which there are mushrooms that certainly there was an epidemic in Scotland where they were imported from Norway. Balkan nephropathy, and Chinese herbs. Chinese herbs, of course, again caused a clutch of renal failure amongst young women using herbs for slimming. Contaminated food, the most recent being melanin, in China, where they use this to substitute for nitrogen in food. And then drugs of abuse, analgesics, non-steroidals, and heroin. Very briefly, any disease or nephrotoxic effect starts with a single event. So if I can find the arrow, I've got it. So we start with exposure to a nephrotoxin or an onset of disease. You could get build-up of the concentration of the toxin. You get a biological effective dose. Then you get an early biological effect. That results in altered structure and function and clinical disease. So the level effect goes across there. The point to notice is desired screen is this point where you can actually have an effect. The current state of art is here. So this is, so you have normal epithelium, you get ischemia or perfusion resulting from toxicity, you get damage, leakage of enzymes, for example, and this is where your biomarkers have an effect. Then you go on, and this is non-reversible necrosis and apoptosis, resulting in cell death. At this point, you get GFR going up, serum creatinine and blood urea up. So we really need to move to as much diagnosis at this point. Just as a very old diagram, it's quite useful. Basically what happens is energy metabolism, it changes. This affects the integrity of the membranes. The lysosomal enzyme leaks, cytosolic enzyme LDH comes out, you get movement of calcium, and you get shedding of brushboard, and out come the protein. So this is how the biomarkers get into the urine. So what are the applications of NAG? Well, clinically, AKI due to transplantation can be used in intensive care because for example, the effect of cardiopulmonary bypass, in infection, and also you can use it to attempt whether dialysis will be necessary or not. Clinically, you can monitor nephrotoxic drugs. It means that you can use cyclosporine and cisplatin. It's been used in development of drugs, and CROs particularly interested in this because if they want to know early if there's a nephrotoxic effect and how they can do something about it. You can screen at-risk populations, for example, where you expect a risk of renal disease due, for example, from urinary tract infection. Industrial monitoring, where there's exposure to, say, heavy metals and solvents, and in the veterinary area. The value of early warning of renal nephrotoxicity, why is it useful? Well, it allows modification and termination of study or trial. NAG can be used to monitor treatment when nephrotoxic drugs are used. Excretion of markers are related to dose level used. In other words, you can adjust or titrate the level of a drug used on the basis of the excretion. We've done this with cyclosporine and some of the antibiotics. Drugs are initially site-specific, and markers can be used to study the mechanism of drug toxicity. And they can also, as we mentioned earlier, indicate renal involvement following urinary tract infection. That is when the infection moves up the ureter to the kidney. So in about 1995, the National Research Council of the USA came out with a core battery of non-invasive and simple tests. So NAG with lysosomal enzyme, aluminum peptidase, which we've mentioned, maximum urinary osmolality, in other words, some concentration of the urine, ability to the kidney to concentrate urine, serum creatinine, which all clinicians require, and then albumin and proteinuria, a dipstick. This would, now you would do microalbuminuria, and low molecular weight protein urine. So it's not too dissimilar from what I showed earlier. Now what I want to talk about now is the NAG test kits which we have available. So first of all is the Calibrant kit, and this comprises 3 bottles. Bottle N, and that's a solution of the substrate. Bottle A is a mixture of crystalline buffer salts. Bottle G is the color development buffer. This comes with 2 vials of Calibrant, set of instructions and method sheets. So you look down the right-hand column, you'll see the codes. We have 3 types of kits, and they were developed for different reasons. So the 731085 was developed for small experiments. In fact, it was requested by the Japanese who were doing a series of experiments, and they wanted to do the assays in blocks of different times, but a small number of assays, so it was a small trial. So basically, this can be used on a small scale. It's really for research. The 73129050, this does 300 automated assays and 50 manual tests. The 7312900100, this does large number of tests, 600 automated, and manually it does 100. The most popular one is the 50-12950. This is the most common. This is when you've got very large studies or suddenly large lots of samples at once, or this is where you've got small numbers in blocks. We also produced a series of controls, high, medium and low, and including, as well as the NAG enzyme, we've included different levels of creatinine. So this is a picture of the kit. The kit is subject to modification, but there's the bottle N, which contains the yellow substrate. This is bottle A, which contains the crystalline buffer. And this is bottle G, which contains the liquid stopping buffer. And there's the 2 calibrants. So we have 3 controls, high, medium and low. These are readily dissolved in a mill of distilled water, so they're very easy to use. They're very stable. They can be stable for up to 2 years. So the manual procedure, we basically made as simple as possible. So we mixed N with A, so you pour liquid N into solid buffer A, aliquot 50 microliters of sample, it can be urine or serum. Then you add 750 microliters of solution N plus A, incubate 37 degrees for 30 minutes, add 250 microliters of color development buffer G, and then you read it out at 505 after 10 minutes. So if you look here, this is an example of an automated procedure, the Beckman. The difference is, I don't know whether you can see this, but there's a much lower volume. It's 10 microliters. The incubation time is short, which means you can do many more samples via the automated system. The actual data obtained is actually very similar. Oops. Sorry, I left out the specification. So if you look, we've got the various catalog numbers. You can compare the automating method with the manual method. It gives you a rough idea of the key things on here is sensitivity, which is 15 micromoles per hour per liter, or 0.25 international units per liter, or the manual method, which is 15 micromoles per hour per litre, or 0.25 international units. So they're very similar. Well, in fact, they're identical. Range, again, is probably easier international units, 0.25 international units to 200 units per litre. So that's a very wide range. The incubation time, automated method, about 12 minutes, 40 minutes altogether on the manual. Wavelength, depending on the machine you're using, is 520 nanometers. It's fairly broad optimal peak. The manual method is 505. Regulatory status, they're both for in vitro diagnostic use only. So these are examples of some of the method sheets we have available. There is a training video available which you can obtain or access to. So let's say a little bit about the spectrophotometric method. This was the second series of substrates, and one that came out of this was a VRA glucnac substrate. And there are some advantages in this, particularly where you need high sensitivity. The end product is an intense red color, and it's stable at 505 nanometers. And this means that you don't need a calibrant. So for the stability, it means that you can operate without a calibrant. And the advantage of that is that you can use Lambert-Beer's law for the calculation. The enzyme reaction is carried out at saturation, and the release chromophore has a high extinction coefficient of 38,600, pH 9.5, and that gives you the result in high sensitivity. That's a very high extinction coefficient. Rhodopsin is the highest naturally known, that's about 45,000. So both the MMP and VRA do have high extinction coefficients, and this gives their great sensitivity. So what's it's been used for? The procedure is mainly used for the assay of urine from children, where samples are often dilute and high sensitivity is required. So the kit, in this case the substrate V is a solid, and bottle R is the incubation buffer, so that's liquid, whereas bottle A is the color development buffer. Again, it's supplied with instruction and method sheets. So some properties. Its kit shelf life is about a year, 2 to 8 degrees. And it's okay for about a week once opened at 4 degrees. Solution R is added to bottle V and shaken until dissolved. It can, if there's any problems, then it can be heated to 70 degrees 3 to 5 minutes. Again, it can be stored up to 4 degrees centigrade for 1 week, so you can keep it in the refrigerator. 700 microliters of V plus R are added to buffer A. Buffer A are added following mixing, and again you read at 505. In this case, you do need a reagent blank, and you calculate the results by the extinction coefficient. What are the advantages of this kit? The measurement is carried out at enzyme saturation. That gives the release phenol is stable at 9.5 to 10. You don't need a calibrant, so that simplifies it. It means you can run it in any sort of laboratory. The unopened kit can be kept at room temperature. V plus R mixture can be used for up to 7 days if kept in the fridge. High extinction coefficient gives the method high sensitivity, and the range is rather less than the MMP. It's 10 to 2,000 micromoles per hour. Sorry. There we go. Going back. Yeah. Is that correct? Yeah. So the specifications, to compare this with, at the moment it's not being put on the automated machines, though obviously it can be semi-automated. It can be used, again, human and animals. You can look at serum, urine, plasma, and other tissues as well. You could do, the kits we've got can do 100 tests or 50. It's used where you don't have lots of samples, so that would be usually quite adequate. Sample volume is quite low, 50 microliters. Sensitivity goes down to 10 micromoles per hour per liter. The range is, again in international units, 0.16 to 33. Incubation is 30 minutes, wavelength 505. So it's very easy to use once it's set up. So do we have any competitive advantages? Well, I think we do. There's considerable technical backup since we actually developed the procedure, and we've talked to lots of labs who've been using it. So we know many of the problems that can arise in various types of studies. It's flexible and adaptable, so it can run in the most advanced hospital laboratory down to very simple procedures in not so well equipped. For example, some of in developing countries it can be used. We can supply the Calibrant, and we also supply high, medium, low controls. It's well established, there's a long history, there's lots of literature which we can provide. It's got a 510K and CE mark registered, so it's registered in the US and in the European Union. There's a company trademark, Rapichrome, and the other advantage, the kit can be transported. All the kits can be transported worldwide in ambient temperature, so you don't have any problem of having to use dry ice or excessive cooling. So what are the key benefits of the PPR kits? It's first read the titles, that's well established, high specificity, very adaptable, simple, rapid and easy to use, and there are various types of kits which have been designed to meet the types of problems that are met in a variety of different laboratories. Well, thank you all very much.
Okay, I'd like to thank Dr. Price for a great talk, and I hope that everybody has enjoyed it. I just want to bring this to the last slide. Actually, my contact information is there on this slide. So without further ado, I'd like to just see what our questions are. We do have a few minutes left. And let me just see if I can get this to be a little bit bigger. Okay, so I do see one question here from Elizabeth. And the question is, would you be able to use the isoenzyme difference then to help distinguish between glomerular and tubular injury? Dr. Price, would you be able to comment?
Yes, can you hear me?
Yes.
Yes, you can. There's quite a difference, but we have done studies where we've initially with animals, now we looked at patients as well, Well, you can look at the serum pattern, look at the kidney pattern, and then you can look where there is glomerular damage. For example, some types of glomerulonephritis, or you can induce glomerular damage using a reagent, and you can see a difference. You can either do this by electrophoresis, which is a bit, or there's simple ion exchange chromatography can be used to distinguish them. So there are distinctive patterns. This is shown quite clearly with some antibiotics, actually. So we have published stuff, and there is work available. We could perhaps send some references if the questioner was interested in that.
Excellent. Okay, so here we are, another question. Thank you very much for the presentation. I noticed NAG was reported as nanomole per hour per milligram creatinine and as units. Is there a way to convert between nanomole and units of NAG?
Well, it depends on the, we've done studies with a range of different animals, and the advantage of animal studies is you can usually get time samples, so it's much more common to have a time sample or 24-hour values, but it's much more difficult with humans. There's some studies here where they have metabolic rooms where the people stay for 24 hours. In that situation, you can get a very good 24-hour sample, but it's much more difficult. So the rule of thumb really is to use creatinine as a measure of concentration of urine. It's a rough measure, and it does do the job, really. It has been related to creatinine clearance, but basically if you work the enzyme activity against the micromoles of creatinine, this gives a good rough measure of the concentration of the enzyme in the urine.
Okay, one last question I think here is, can the kit be used to monitor kidney injury in rats or mice, i.e. is there a sufficient homology in NAG?
The isoenzymic forms are different in rats and mice from human, but you can use the actual assay to measure renal damage. We've done that. You can monitor changes. The isoenzyme patterns are rather different and not quite. The human, they are very distinctive, which is why they've been used in the genetic area, looking at development of Tay-Sachs disease in Ashkenazi Jewish populations. So unfortunately, the NAG enzyme in rats and mice, although they are different, the kidney form is different from the serum, and you can distinguish them. It's not the really rather nice distinction you get in human.
Okay. And one other question, will it be approved for clinical applications?
Sorry, could you repeat the question?
The question was, will it be approved for clinical applications?
Well, it has a 510K. I'm not quite sure.
Right.
Whether
So
that covers that question.
maybe it depends on, maybe the question is geared more towards its intended use. But if that participant would like to send me a question directly, we can certainly talk more about it if we didn't answer it fully.
Yeah, well, it has been used to monitor drugs and disease in patients. I'm not quite sure, because we're in Europe, of course, what the exact situation in the States is, but the 510K means it can be used clinically, I think.
Right, right. Okay, there is another question here. How about isoenzyme differences in monkeys and dogs?
Monkeys, we've done some work with monkeys, and they're quite similar to human. Dogs, yeah, they are, the serum and urine are different, but again, there are slight differences in the physical forms between sort of different species. But monkeys definitely resemble human. But again, they're not identical. There is some published work. It's quite old now, but where this has been done.
Okay, it looks like we're just about out of time, and that was the last of our questions. I'd like to remind everybody that the webinar will be forwarded to you in the next couple of days. If you have any additional questions, please feel free to contact me directly. You can also visit our website. And thank you again to Dr. Price. And I hope you've all enjoyed it. We'll have a great day.
Thank you.